Change Incorporated.
Thank you so much. And then I do see someone, I believe, under Tug River. That might be linked to another profile. We can just move forward, no worries. And Robin Riddle, please. I see that you unmuted, but we're unable to hear you, so go ahead and chat in. Also, before we begin, if anybody is new, Mitra is going to be attaching a link, and if you please fill that out for the CE office, for us and for them, everything's confidential. They're just kind of requiring more information, and if you want other projects or to be added to listservs, that's an easy way for us to know those items as well. And then last but not least, Mitra.
Hey everyone, I'm Mitra with Project Echo. Thanks, Elizabeth.
Perfect, thank you so much. All right, so if we can go ahead and begin, Dr. Bailey, I'm gonna go ahead and pick up your case. Is that okay?
Yeah, that's great. I will really quickly introduce Robin and Leanne for them. So Robin Bridville is a nurse practitioner that started working with us at Tug River just a little while ago. And Robin, I can tell you, you have the same computer I do. Right above where your camera is, if you slide the slider to the right, you'll be able to see your camera will come on. That's your issue. Anyway, so they are working over at their new office, which is in the Southern Highlands in Mercer County. So Dr. Feinberg, Tug River now has clinics in all of your study region. So don't get too excited. But yeah, so we're hoping to get Robin kind of trained in hepatitis C too, because we see all the patients that are coming through Southern Highlands addiction treatment programs.
Great. Thank you so much. Thank you for those introductions.
All right. So I guess we can jump into my case. I actually have a meeting that starts in about 10 minutes that I have to be at. So I'll try to make it quick. This patient is very straightforward. She's a 51-year-old female who had a tragedy in her life and started having IV drug use back in 2007. She used IV drugs until about September of 2020. At which time she kind of got into a stable relationship, and her partner was able to kind of help her a lot with that. She is not currently in a Suboxone program, but she is taking Suboxone. So she has a family member that's in a Suboxone program. There's a very popular Suboxone program here in Southern West Virginia, Anchor Medical in Beckley, and they're very popular because in addition to prescribing Suboxone, they allow their patients to be on benzos, and they will prescribe them benzos. So she's on the wait list for that program, but she hasn't been admitted as a patient, but she has a family member that's in that program, and so currently they're giving her half their prescribed Suboxone and half of their prescribed Klonopin. So while she is still technically using illicit drugs, she is very stable and has a stable source for those medications. So she has been very adherent to our treatment plan and her follow-up appointments. Life is very stable. She, as far as her lab goes, it's always kind of hard for me to look at them on the thing, so let me pull her up over here. Sorry, my computer's running slow. I'm asking it to do too many things at once. Labs were not super exciting. Her platelet level looks okay. Her ferritin was on the high side, but she doesn't have hemochromatosis. Here we go. All right, I got him pulled up in the way I like to look at him. Her AST and ALT were pretty darn high. AST was 126, ALT was 250. When we look at her fibrosis score, her fibrosis score wasn't bad. It was F0, I believe. It's pulling up now. Yeah, she was F0, no fibrosis, but her necroinflammatory activity was A3. So her virus is pretty active right now. All of her Hep B stuff was as expected, negative. We are, of course, starting her on the hepatitis. We started her on the Hep A and B vaccine series. I think she might have actually finished that up. Her viral load was about 1.5 million. She's genotype 1A. I think her treatment plan can be very straightforward. She's a 1A with a not so bad viral load, never been treated before. I guess so she could take virtually any of the medications, but we'll just have to look at drug interactions as far as that goes. But my question with her is, ideally she would be in a Suboxone program and getting her medications prescribed to her. But the good thing about this patient is she's really stable, even though she's not in a program. I feel 100% comfortable giving her medicine and treating her at this point. I think her risk of relapse into her risk factor, which was IV drug use, is relatively low. But I guess my question is Medicaid gonna throw up some roadblocks for me in getting her treated? And what are your all's thoughts about that? And actually, so in addition to knowing the things that I know about her, we have an addiction counselor who works with our Suboxone program, who saw her and evaluated her, and she feels the same way I do. She feels like her chances of relapse are low. She thinks it would be reasonable to go ahead and treat her. She doesn't think she's going to relapse into IV drug use. And this patient kind of is one that, she was able to say, even if I did relapse, I think I could keep myself from shooting up. So
let me start, Joanna. It's wonderful to see you. It's been a
good
long
to see
time.
you.
So, she's not required, of course, by Medicaid to be on Suboxone by prescription. It's really common for people to buy it on the street when they have trouble getting into a program. We have analyzed, but not yet published, the results of the PCORI funded study that we did, HERO, Hepatitis C Real Options, where we gave curative treatment to people who were active users. And, in the per protocol analysis, I don't know, it's like 89 or 90% of people cured. So even if she did relapse, and people do relapse, there's no reason not to treat her. And if she relapsed in the middle of treatment, there would be, in my mind, no reason not to finish the treatment, because there's no reason not to do that. So I think that is, I would proceed with that. Since she's in Wyoming County, can she get into the, has she been referred to the Southern Highlands sites at either Welch or Mullins? The Beckley program is, as you know, is so problematic, right?
Mm-hmm. Yeah, she has been referred to several, so she could get into a Suboxone program other than Anchor Medical. She's just not willing to, because she doesn't want to go off of the benzo, doesn't want to go off Klonopin.
Ah, okay. So
Mm-hmm.
there's the issue.
Yep.
So, okay, it's a little concerning when someone's got, right? People get habituated to benzos too.
Mm-hmm. Yeah.
It's a little concerning that she's been in recovery from opioid use, but is continuing with benzos. So that's why she wants to go to Beckley. Okay. That makes that totally clear, because, I think those of us familiar with the Southern counties know that program is deeply problematic.
Yeah.
But even with her benzo use, I would proceed to treating her. I don't know, John or Kaylee, if you feel any differently.
No, I have no concern. I would view that Medicaid consent form as is what it is. It's a barrier to therapy, and holds no merit regarding efficacy of the treatment.
Mhm.
So you can see my interest in upholding that consent form as something that we need to really validly consider. I would treat her. Yeah, and in terms of treatment options, she's a genotype 1A. I think everything's on the table with the current blood work, with the exception of Zepotir, because you don't have the NS5A polymorphism. So you could do Harvoni 8 weeks, Epclusa 8 weeks, or I'm sorry, wrong word, 12 weeks, or Mavorite 8 weeks. So your 2 8-week options would be Harvoni or Mavorite. Interestingly enough, her AST, APRI, so AST, the platelet ratio index, is elevated at greater than 1. It's just one of these people who we don't think she has cirrhosis, but it's probably worth getting a tiebreaker modality such as an ultrasound, even if you can't get elastography, at least just to get an ultrasound to make sure you don't have any morphology consistent with cirrhotic liver. I'm sure you don't, but especially with that F0 on fibers on the serum biomarkers. But
Right.
remember, as we do march forward, treatment's one part, and then the long-term HCC screening is another part, and really depends upon if there's fibrosis. And our FibroSure would say no, our APRI would say possibly, but I do think APRI is too falsely reliant on this situation on the elevated AST number.
Yeah, I think so too. And her, we did do an ultrasound on her, and it was normal, not even any fatty liver. So I think she's just inflamed. I think if we get rid of the hepatitis, I think the AST and the ALT will drop back to normal, or at least close to it. Hope so anyway.
Totally agree. Yeah, platelet count of 253 is comforting.
Mm-hmm. Definitely. And I'm just looking, we did have her sign her Medicaid consent form. We mailed that to her. So I didn't go over it with her in the clinic, but looks like she marked everything appropriately, though maybe not honestly, but I'm not willing to dispute that. I'm going to take her word for it.
Love it.
Yep. So, all right, guys. Well, I got to run off to my meeting, but I really appreciate your help. And I think Jenna will probably hang on. Bye.
Thank you so much, Dr. Bailey. Have a great rest of your day.
You too. Bye-bye.
Bye-bye. All right, thank you so much. I think we'll go ahead and get started with Dr. Peters, and thank you, Dr. Gilfus and Dr. Feinberg, for providing some recommendations. And if you have any more, or anybody else does, please send them my way so that I can send them to Dr. Bailey. All right. All right, Dr. Peters, I have it up for you.
Thanks. So I saw this guy about a month ago. He's a 50-year-old Caucasian gentleman who is a healthy, fit police officer who contracted hepatitis C in Florida over 10 years ago. He was started on treatment by an infectious disease specialist down in Florida years ago. And that had to be discontinued just because of side effects. He said it just made him feel like garbage. He was on pegylated interferon, one of the interferon regimens, and just didn't tolerate it well. He says it was a long time ago, but as he recalled, he completed about 2 months worth of medication, didn't appear to respond to it, as far as his viral load was concerned. And it made him feel like garbage, and so he stopped it and hasn't addressed it since. As far as comorbidities, he's really he's a healthy 50-year-old guy otherwise. He gets recurrent cold sore outbreaks and takes some acyclovir for that. His medicine's lisinopril, Viagra, and a testosterone replacement. He is immune to both hepatitis A and B, he started the vaccine. So we started him on the vaccine series for Hep A. His second one he'll get in 6 months. He's immune to hepatitis B. His BMI is a little bit elevated, but he's a muscular version. He's a more muscular version of a 28 BMI than I am, let's say. So As far as other labs, he's everything really looks good on him. He's a F1 to 2. His viral load is about 3.5 million. Nothing else on him is concerning. His vitamin D was fine. Actually, it was over 40, so it doesn't need replaced. The reason he would be boring if it weren't for the history of partial treatment, and I always kind of have a tough time of wrapping my head around this. I thought it was a good one to bring up. For a discontinuation of treatment that is brief because of side effects of treatment, rather than a patient who failed to respond to treatment with their hepatitis C, I always wonder if you have to consider that when you're looking at the algorithm as to what medication to choose for this person. As I understand it, if you just ignore it and pretend like it didn't happen, you can treat him with anything. 8 weeks of Mavorite would probably be the simplest thing for him and a good choice with the other medications that he's on. If not, I don't know if 12 weeks of Vosevi would be better. The only other question that I had for him was if there was any reason. I don't do really any testosterone replacement or testosterone supplementation therapy as part of it's just not one of my clinical interests, and it's well outside my area of expertise. So I don't know if there's some reason to stop the testosterone replacement for him, but we talked at some length about once we cure his hepatitis C, that some of his testosterone level may fluctuate as a result of his liver being able to do what it needs to. And he'll follow up with the doctor that prescribes it for him as to what that is. So I was just curious what your guys' thoughts were.
Cool.
Go ahead, John.
Man, so good to see you, brother. Missed you, Greg.
It's nice. It's nice you to say so. It's I don't see you, but it's nice to hear you too, buddy. Thanks.
Oh yeah, this is the more flattering version of me. Your big black screen. You don't have to. So two things. About 3-4 months ago, HCVguidelines.org made it exceedingly difficult to, and this is this is not critical. This is a roundabout explanation for good news. Made it really hard to see what to do on patients who had prior PEG interferon therapy. If you remember, you go to the main webpage, hcvguidelines.org, for those who are ever needing a quick, awesome reference to remember how to treat patients who either are treatment naive or have treatment failure. But if you go there used to be, and if you go into the section of retreatment of patients whom prior therapy failed, there used to be like 25 pages. It was a terrible read. It was a challenge. And it's because they had a whole bunch of stuff about people who had prior exposure to PEG interferon. And basically, I went to look this up because I can, like you, Greg, I can never remember it. So I went to look this up for a patient a couple months ago and realized on. And so basically, in the most recent iteration of that section at hcvguidelines.org, they have really eliminated retreatment recommendations for people specifically who have interferon or first-generation protease inhibitor failures, because the cure rates with the modern direct-acting antivirals are, for all intents and purposes, the same. If you still wanted to feel better about that and look up a resource that actually still lists it, since they don't even tell you on hcvguidelines.org anymore, you could go under the package insert for any of the 4 major drugs that we use, Mavorite or Zepatier or Harvoni or Epclusa. And just to comfort you, given a guy like this, there's no changes to any of the recommendations. And under the package insert, you might see a common comment will say PEG interferon experienced. They don't say failure, they just say experience. So I don't know what experience means either. Like you, Greg, if that means experienced as in like I've had 1 dose, or if it means experienced as in I've had 48 weeks. And then they'll also have a second tab that says PEG interferon experience plus NS3 protease inhibitor treatment experience. That's these were these drugs, telaprevir and boceprevir, that were available from 2011 until about 2014. They were drugs that brought our SVR rates during the PEG interferon era from the 30s up until the 50s to 70% range. So they were better for what they were, but nothing compared to current ones. But long-winded answer to, yeah, you can't find that info because it doesn't matter. And you don't need to go to the realm of Vosevi. Vosevi, I want you to keep in your mind, is more something for a DAA treatment failure, whereas basically this guy's sky the limits. You can treat him whatever you want. Regarding your testosterone question, you know, I have quite a few patients on that, and just a few things. The major thing you got to do is watch hemoglobin and liver enzymes. And I think it's interesting. I can't remember if he was a smoker or not, but his hemoglobin's pushing 17. So you can certainly see a little polycythemia, and liver enzymes can be high, but his are normal. So I think it's a non-issue overall as far as my limited experience from that perspective. But cool case, and that's all I got.
And I would just add to that, Greg, that really ideally, you want not only someone's vitamin D level to be in the normal range, you want it to be on the high side. So you want it to be at least 60, 70 for optimal immune responsiveness. So if he's 40, you know, I would start him on a, you know, maybe a month's worth of high dose and then switch him to 5,000 units over the counter every day, because you really want him better than, I mean, 30 is the bottom of normal. So you really want him higher than that. And I also noticed he was on sildenafil. So somebody is treating some level of sexual dysfunction, right, with the sildenafil and the testosterone, and whether his testosterone level is really low or not. You know, it could be one of these sort of men's clinic places that promised you you'll enjoy life again and give you everything in the book for it.
We actually kind of had an interest, I don't know, a more insightful conversation about that. I always kind of try to preface as I'm preparing patients for treatment with the expectation that something's going to feel better with them, because oftentimes when you cure hepatitis C, something does, you know, rashes go away and arthritises get better, and, you know, weird numbness and tingling and depression, you sleep better, and you just don't have, you know, 3.5 million copies of a virus that's not supposed to be there in every single deciliter of your blood that's coursing through your veins. And I've found that to be tremendously helpful. And I definitely told him that his sex life might improve as a result of that. And I don't know to what extent he may be disappointed in that. At least he won't have hepatitis C anymore. So I'll take it.
Right. Well, you know,
Love it.
as I said, that there is something of a racket in these sort of men's health approaches. To me, it does not seem quite appropriate to give people testosterone if they have an appropriate level for age, right? It's, you know, at 50, your testosterone level isn't supposed to be what it was at 20, but it's still supposed to be a functional level. But you kind of never know with these, you never know. You know, you might, out of curiosity, ask him, was the level tested? Was it really low? Or, you know, but at any rate, yeah, he may feel better overall. It may be less depressed. And that may be, help his sex life. So there you go. And I totally agree with John. Even a full course, a full 48 weeks of interferon plus whatever, even if it included, boceprevir or whatever, I would have no concern about treating him now.
Thank you so much for your feedback to both Dr. Gilfuss and Feinberg. Does anybody else have any questions or comments? And Dr. Pollywall, testosterone replacement topic would be a good endo. I totally agree. That's a great suggestion put down. But yeah, if anybody doesn't have any questions, I'll give you a few moments and then we'll move forward with the didactic. Thank you so much, Dr. Peters. All right, I'll go ahead and share my screen. Is that okay with you, Dr. Feinberg?
Sounds good.
Perfect.
Okay, here we go. Can you see that? Is it on?
Is it on?
Yeah, we can see.
You guys can see it. Can you see it, Dr. Feinberg?
I can see it, but the issue
Okay.
is everyone else. After a
Yeah,
year,
we can see it.
Okay, perfect. I know I have two screens. I'm still playing around, so let me know.
you know what? After a year of Zooming, I still always don't get this right. So I actually wanted to talk to everybody about non-alcoholic fatty liver disease. First of all, you're all PCPs, and this is a big problem just in medical care, but it really can be a serious issue for people with chronic Hep C because, you know, it's another irritant to the liver and something else that can enhance fibrosis. So with that, let me go. So this is what NAFLD, non-alcoholic fatty liver disease, is how it's defined. And it's easy to get this confused, I think, because people have such a tendency to throw these terms around interchangeably, NASH and NAFLD. They're not the same. So NAFLD simply means that you got fat in your liver for whatever reason. But then there are two types of NAFLD. There's just what people call simple steatosis or simple fatty liver. So there's some fat deposited in your liver, but there's really little or no inflammation that accompanies that, and therefore there's no cell damage. Like unlike that, you know, the patient Dr. Bailey presented, whose transaminases were really high because there was a lot of ongoing cell damage, and this typically doesn't progress. So it's not fabulous, but it's not harmful. Then you have NASH, which is the acronym for non-alcoholic steatohepatitis. And this is fat in the liver plus the inflammatory component, and therefore the inflammation, of course, the invasion of white blood cells, and they're helpful, but sometimes nasty enzymes can cause liver cell damage and result in fibrosis. And usually people have one form or the other. They either have simple fatty liver, right, or they have NASH. Occasionally people will progress or move from sort of one diagnosis to the other, but by and large, they are typically remain pretty distinct. And one of the sad things about NASH is it has overtaken chronic hepatitis C as the most common reason for liver transplantation in this country. And as you will see from the following slides, it'll make perfectly clear why that is the case. So here is a heat map of the world for where looking at NAFLD prevalence, and you see the United States is red hot, as is Australia, and a string of countries from Southern Europe, you know, down through India. And this is not good, right? This is shows you that there's a significant world burden. And the more the developing world picks up the resource-rich world's eating habits, right? McDonald's and fast food and everything else, the more they're going to have this problem, because this is the metabolic picture that underlies obesity. So the next slide, there we go. So in 2019, more than 6 diabetics and 9 severely obese people out of 10 have NAFLD, right? If you gaining weight and your metabolism is dysregulated by diabetes, then you know you're at high risk. But the other interesting thing is even people who have normal weight, 25% of them have NAFLD. I think it really reflects our diets and probably our general lack of activity. So here is moving on to NASH, right? The harmful form of NAFLD. There's approximately 30 million people in the US who have this problem. And as I mentioned before, it's now the most common reason for liver transplants. And actually, the other really interesting thing is almost 10% of all children, and as you know, if you look out in the street, you see all those roly-poly children, thus we have a lot of childhood obesity now. So, you know, it really confounds things. Come on, machine. Where's my next slide? There we go. So the pathogenesis of this is sort of a perfect storm. There's both prehepatic and intrahepatic things going on. The prehepatic is things like fat overload, like obesity, especially people who have visceral fat, big bellies, right? As opposed to big rear ends, insulin resistance, things like that are outside the liver, and hyperphagia. I love that, sort of a very technical term for eating too much. But then inside the liver, in a biochemical sense, just the whole biochemical pathways for lipogenesis and the metabolism of triglycerides contributes to this. There we go. So here is the familiar, this should look familiar to you from like how we described what happens with Hep C. So, and it's all about fibrosis, right? So NAFLD goes the same path. You start with fat in the liver, 10 to 20% go on to fat in the liver and inflammation. Another 25 to 50%, half of those people go on to develop fibrosis. And at the rate of about 2 to 5% per year, you develop cirrhosis as a result of NASH. And then, of course, if several percent go on to develop hepatocellular carcinoma. So if you look at from the starting point to the ending point, you're talking about up to 5% of all people who have fat in the liver will develop cirrhosis over a couple of decades. So now you begin to see, why is this a problem for people with chronic hepatitis C, right? Because you've already got one irritant to the liver, and one irritant that is inciting fibrosis, and now you got fat in the liver, and that's inciting fibrosis, and this is just like drinking on top of Hep C. Anything that's a hepatic poison or that's damaging to the liver kind of accelerates the fibrotic disease process. So I just showed this slide because really the thing to think about besides just fat in the liver is really have to think about all the manifestations of metabolic disease that we see in our patients, right? Type 2 diabetes, cardiovascular disease, these all play a role because of course, lipogenesis is part of the pathology of all of these diseases. And you stop and think about, what is West Virginia? Are we number 2 for diabetes in the nation and number 1 or 2 for cardiovascular disease? So we got lots and lots of reasons for our patient populations to have multiple pathways by which the liver can be damaged because of fat on top of their chronic Hep C. And here is a chart that shows you NAFLD is a manifestation overall of metabolic disease. And this is data from general populations, not people just with Hep C. And when you look at on the x-axis and look at the prevalence of obesity, well, there we are, USA, right? Korea, India, they're on the right-hand side. And you can see that NAFLD is increasingly, and a nice straight line upward, increasingly more common in people who have metabolic disease, right? So how do you screen for this? So in addition to all the typical workup you do for Hep C, you get a fasting blood sugar, you get a hemoglobin A1C, and you get a lipid panel, ideally fasting, but a lipid panel nonetheless. And then I think really the initial test to look at tissue is an ultrasound. And then depending on what you see on the ultrasound, you might go on to do elastography, right? Because that measures fibrosis, or you may wind up doing a CT or an MRI, and it'll really be driven by an individual patient situation. And how do you manage NAFLD? Guess what? You lose weight. Easier said than done, right? But it's all of these elements, right? Reducing the calorie intake, increasing exercise, eating healthily to begin with. Now, this is a real challenge, right? It's a challenge for many, many people in West Virginia. First of all, because lots of people, especially in rural areas, live in food deserts or fresh food deserts. McDowell County doesn't even have a grocery store. anymore. You want a head of lettuce, you got to drive to Pineville or Beckley. That's not so good. So, you know, both poverty, because fresh food is not cheap, and lack of easy access means that eating habits are not stellar. You know, there's plenty of Tudor's biscuit worlds, but not a lot of places to get salad. So, you know, I think it's reasonable to think that if you have access to nutritional counseling, that is useful too, just to teach people how to make better choices about their foods. And of course, if they're already diabetic or pre-diabetic, then they need tighter glucose control, right? And that is, it's its other, another whole another topic and set of grief. There are no approved treatments yet, but many, many, many are being studied. There's already been a whole bunch of phase 1 going into phase 2 studies. There's a lot of publications. There must be 8 or 10 different approaches now. Some of them using drugs that we use, modern drugs that we use for diabetes that are under study for this, but nothing has been shown yet to, you know, to reverse this, to make a difference. And the old-fashioned thing, even though it's hard, works. So if you think about dealing with NAFLD as a pyramid, right, then the base of this pyramid is lifestyle modification, what we just went over, right? Eating better, eating less, exercising more. And then, you know, if these are people who already have components of the metabolic syndrome, diabetes, et cetera, focusing on tuning that aspect of management up. And as I said, there's a lot of liver-directed pharmacotherapy being studied, but we're not there yet. And then, of course, for the unfortunate people who, you know, been living with this for a long time, you know, you wind up ultimately sort of managing the complications of cirrhosis. But it would be nice not to get there. So I think that's my last slide. That is my last slide. So I'm happy to take any questions about that. But anyway, the reason I really wanted to mention this is, right, you've got patients that you're evaluating who already have one good reason to develop liver fibrosis, and they don't need a second and a third. So it's just, I think, really important to be aware of this and, you know, transmit that education to your patients. So I'm happy to answer questions.
Great, thank you so much. All right, if everybody wants to just unmute or chat in, let us know your questions. Thank you so much for your presentation. It's very eye-opening, and I think we can all say the last year has been a challenge. So I'm kind of curious of how that's been for individuals, including myself. I know I've been bad this year, so just any questions you have. I think Dr. Polywall unmuted, so go ahead.
Dr. Feinberg, thank you for the presentation. My question is, do you know whether when the people lose weight, okay, either with medicine or naturally, is it reversible to some extent?
Absolutely. And you can see that. You can do a liver ultrasound, you can show that there's significant steatosis in the liver. People lose weight. You repeat that liver ultrasound, the liver looks so much healthier, either has a lot less fat or the collections of fat actually disappear. So, I mean, that's why it's really important to educate people. However, as we all know, changing life habits is really difficult. You know, and if that were the case, we wouldn't have so many people with type 2 diabetes. So, you know, I think the real struggle is getting people's behavior to sort of line up with what they need to do for their health. So I don't minimize how hard that is, Dr. Polywall. I think it is really difficult, but people who are motivated, and I've seen this, can really do, can really absolutely reverse this process. You know, maybe, I don't know, you know, I don't, scare tactics have never seemed to me to be an optimal way to manage patients. But one of the people that I know that really had an incredibly successful response to changing his eating and losing weight was told by the hepatologist that, you know, he was headed to cirrhosis and a liver transplant, which I think just scared him. But I'm not sure that that is always a productive. Sometimes I think scaring people, this is your brain on drugs. I think people think, oh, scrambled eggs, that sounds good. Remember those old ads where it was like a fried egg and then it was a scrambled egg, sunny side up egg and a scrambled egg. I'm not sure that scare tactics, always work as appropriate motivation. But this guy went ahead and lost like 45 pounds and his liver just clean as a whistle on ultrasound. It was very impressive.
Go ahead, Jennifer, if you'd like to speak. I saw you unmute. Did you have a question?
I'm watching Dr. Peters unmute too. It's the dueling unmutings. But I was just going to say two things quickly. One is that I have found that just people seeing that their liver, just me telling people that their liver enzymes are elevated is alarming to people. They are their own best scare tactic. And not that that necessarily leads to them losing weight, but it's more, without me even saying anything, it's more effective at drawing their attention to the risks to their health that their weight poses. So yeah, this was a great presentation, Dr. Feinberg. Thank you. And I think the thing that alarmed me the most was the statistics on pediatrics, because gosh, what is our future? And I find it much more challenging to help obese children lose weight even more than adults. So anyway, just that comment.
Right. I think I agree. I mean, I'm not a family doc, so I never took care of children, but I know just walking around in the world in Ohio and West Virginia, when you see those little roly-poly children who are almost wider than they are tall, they're usually holding the hand of somebody who is maybe almost wider than they are tall. So I think part of the real struggle there is that you're not treating a person, you're trying to change an entire family's view and attitude to eating, what they eat, how often they eat. And I think that's really hard. And I think, on top of it, it's really, really hard if you don't have access to, if you don't have access to lettuce, then, potato chips are everywhere. So, I think that's a huge part of the problem. It's interesting for our HIV infected patients, this is something we've been dealing with for years, is the metabolic consequences of, altered lipid metabolism and, how vulnerable they are to developing diabetes. And, even in urban areas where there are food deserts in certain neighborhoods, it's just a complete constraint, for what are you going to eat if you don't really have access to the right kinds of food. So I've done a lot of nutritional counseling myself and referred patients to nutritionists, but I think in the end, sadly, a lot of it is just, it's a economic and social political issue, like, what's available in your neighborhood, what can you get to? I think people should be encouraged to, like, if they have yards, grow vegetables. They're so tasty when they're fresh. So I used to give people seeds. You never know what's going to work, you have to think of creative things. You're right. I think you all get 15 minutes of your life back. How nice.
If there aren't any other questions or comments, thank you so much. I do believe this is a really great eye-opening for everyone, and I really appreciate everyone's time today. My only announcement is our next session, and it will take place on April 22nd, and Rachel Mitchell will be discussing drug interactions. All right, thank you, everyone. I hope you have a great rest of your day. Bye-bye.
Thanks, guys.
Thanks. Can you hear me?
Oh, we can hear you, Dr. Rexroad.
Oh, yay.
It's been awesome.
I'm not silent anymore.
You timed that perfectly, Dr. Rexroad.
Yep. Had to check. See you guys.
Bye-bye.